Okay, so we'll just navigate through the e-learning site here, which is really not intuitive at all. So password SIMIR21 and then sign in. My email address. Okay, we can skip adding a phone number. Skip for now. Thanks. And then, so up here, Bernard Lewis, classes, completed, then ACLS review, then review. Okay, this should open up. I accept these terms. Begin assessment. I've already done this course, so don't be worried about making mistakes or anything like that. If you want to play with it, play with it. And then ACLS patient cases is the relevant one, and then these are all different cases down here. The one that I played for the example was the Robert McRae, so that'll open up there.
My chest hurts.
Try to calm down. We'll take care of it.
So this is Robert McRae, who has come in complaining of some chest pain. So this is our user interface to begin with. So it's under the heading of response. All this here. So this is basically the history taking. So in the ED simulator that I suppose we're developing, it says that you choose how much history you want based on how much time you think you should devote to history. So here it's clicking
What happened?
each individual
I suddenly
question.
felt chest discomfort.
When did the symptoms start?
Quite
About
laborious.
45 minutes ago.
What were you doing when the
Very
symptoms
interesting.
started?
But the game,
I was mowing
or
the lawn.
The simulation wants you to click through every single question just to get the answer. Whereas in our thing, it's that you're just provided all the information, make of it what you will. So this scenario is a little bit false in that this patient has come in and doesn't have any of these things checked. So we don't have a blood pressure or heart rate. That wasn't done automatically. So we'll just do that to begin with. Okay, I'll just find my way around here. So ECG and defibrillator. So we'll do an ECG, which the patient would have had on arrival. So little look. Okay, so this guy's ECG has ST elevation, so there and there, and then there's no ST depression, but it's pretty significant ST elevation. Mary Murphy's ST elevation is pretty subtle by comparison to this, but that's neither here nor there. It becomes less subtle the more ECGs you get on her. So let's do his pulse oximeter, so it'll give us a heart rate and an oxygen saturation, and we'll check his blood pressure as well, which will be under auscultation. Blood pressure. So we'll do automatic blood pressure monitoring. So this is something that is kind of available in Resus, but not so much on the floor. So his blood pressure is fine. So temperature, pretty confident is okay as well. We'll just do it just for completion, and then we can give the drug. So
The temperature is 37.4 degrees
Um,
Celsius.
with some oral aspirin and 325, and then we can administer. We should probably sit him up. There's no reason why he needs to lie flat like that.
325 milligrams of aspirin has been given.
And then what else will we give him? We'll put in a cannula. So cannulas in this scenario are there's no mini game to them at all. It's just click where you want the cannula to go, and they give them a go, and they may or may not get it. Usually they get it. Sometimes they don't.
The
If they don't
IV
get
is
it,
inserted.
So we've given the cannula, or put the cannula in.
Ouch.
We'll flush it,
Flushing.
and then we can start giving drugs through it if we need. We should also have taken bloods while we did the cannula, so that isn't automatically done in this. Okay, so we've sent off some
The
bloods.
troponin test is on the way.
The venous blood sample has been sent to the lab for analysis.
Really matter. Maybe he asked to be laid down. So let's see what's next. So we've given aspirin, I think.
The result of the
We'll
troponin
give
test was
some
negative.
nitroglycerin. So we can give that as a spray underneath the tongue. And
0.4
then
milligram of nitroglycerin has been given.
So as in with Mary Murphy, we'll say, we give 5 milligrams morphine, and see how we go. So we can administer that, and
5 milligram of
blood pressure
morphine has been
So something
given.
is come up in the medical record, whether that be a blood test back. So the troponin is negative, which is a little bit unusual, especially given his ECG. But his heart rate and his blood pressure are all okay. So maybe it's just that it's too soon to think that this might be
Chest X-ray has been ordered.
in his troponin, which would be a blood test to suggest cardiac ischemia. But really his ECG is quite typical of somebody having a fairly serious heart attack. So we'll have a look at the exam. So the exam is kind of uninspired.
The results of the venous blood sample analysis have arrived.
It's great in that it exists, but compared to what I would like to do,
We'll leave the room while the X-ray machine is in operation.
not quite it. So we'll try to find the exam first. It says examine and then head to examine.
The X-ray has been sent to radiology for processing. The results will arrive shortly.
Auscultate maybe. Okay, so we can have a listen to the lungs.
The breath sounds are normal.
Breath sounds are normal. Listen to the heart. So this kind of
I can't
clicking
hear any
around
abnormal
to
heart
examine
sounds.
that the benefit and the value in it is nil, really. You know, why not just give me all the
X-ray
information? I
results have
know where
arrived.
the stomach is. This isn't teaching me anything, and then we listen to the stomach, by clicking on the stomach.
I can hear normal sounds.
Head to examination. So this is the same. So you click the chest. And
He is breathing at
it's breathing.
15
chest
breaths
moving
per
normally
minute.
anyway.
The chest
So
is
medical
moving
record,
normally.
we have a look. No evidence. This is the X-ray report. So we don't get to look at the X-ray and review the X-ray for ourselves. They just give us they tell us what's on the X-ray. So the X-ray is fine. So now we've given him the medications. We've diagnosed it. We can do another ECG just to make sure that we're not missing anything more interesting. So 12 lead ECG. Does anything look better yet? No, that still looks very bad. Okay, now, we weren't expecting the things would be better after a bit of morphine and aspirin, but okay. Something else has come up in the medical record. Not sure what it is. CRP is up. So the troponin is negative and the CRP is up. But the chest X-ray is okay. And yeah, there's nothing really else to say about this one. So we'll just talk to the patient again, see if he feels any better. Do you have any pain?
Do you have any pain?
Yes, I have pain in my chest.
Okay. How bad is the
On
pain
a scale
now?
of
So
0 to
I
10,
think-
how bad is the pain?
Not too bad.
Not too bad.
It's about a 1.
Okay, so maybe we should have found out what the pain was like earlier on.
Does anything make the pain worse?
It gets
Can
worse
you
when I
describe
try
the
to
pain?
walk. It's very tight across
So
my
we'll talk
chest.
to cardiology, see what they say. In with Mary Murphy,
The cardiology
there's an actual
expert is currently
conversation
unavailable.
with the
Please
cardiologist
proceed
here.
on
They
your
just
own.
say we're not available. Keep at it, kind of thing. So then in that case we're happy we've done as much as we needed to, and we can he needs PCI, so we'll send him for an angiogram and stenting, because we think that's where he needs to go. Even though his troponin was normal and his CRP was a little bit high, those are red herrings from my point of view, and we'll see what they say. So we passed it. Yippee. So we got an ECG. We didn't ask about allergies because we weren't bothered going through all that nonsense. We didn't ask about medications, so we lost points for that because we didn't take enough of a history. And then we got everything else right, so that's reasonably good. So then I'll just have a look here. So just in terms of the review or the feedback or the correction, let's see what the detailed view says. No, this is the detailed view. So this is very much so just showing you what everything that happened that was right or wrong, and then here on the edges it shows
My chest hurts.
Try to calm down. We'll take care of you.
Okay, so we can have a little look at what happens when you do it all wrong. So where's my cursor? There. So we can. It starts the same as the same patient. We know what to do. Right. We give the right medications. We do all the right investigations, and we send them to the PCI lab. The thing with this ACLS, American Heart Association simulator, is that you can do mostly everything. So if you want, this man is coming with chest pain, the first thing you can do for him is do a CT brain. So the patient goes to the CT scanner. You don't need to call the radiologist. You don't need to justify the CT scan. You don't need to tell the nurse. The patient just goes to the CT scanner, and then we wait however long. So he's headed up there. I mean, we'd basically finished the case at this point on the previous one, but here we are. So it took him about 6 minutes to go to the CT and come back, and now he's back. So now we'll just do an ECG just for completion. He came in with chest pain. We scanned his head, and let's see what his ECG is like. So it's the same as the last one, relatively similar. Anyway, it's ST elevation. So it's significant ischemia. He's having a heart attack.
CT scan results have arrived.
So let's see what the result of the CT scans is. So the scan is normal.
Ouch!
Well, that's good news for Robert McRae anyway. So then we can say, why don't we examine his eyes? So actually here, you can use a pen torch here to shine a light on his pupils and see what happens. So we shine on his pupils, and okay, and they get smaller as I don't know if you can make that out. So these big pupils, you bring the light to them, and then these small pupils. Okay. I mean, we can try there's a thing with pupils that they initially go small and then they go big again. These pupils do not do that, even though that will be a normal variant and to be expected. So it's pointless this examining the eyes. Anyway, it doesn't really matter. So what else can we do for this guy? The main kind of concerning thing from our point of view is the idea that a player will see the patient and just make a mess of it on purpose. So in order to make a mess of it, you need to really start giving stuff IV. So we'll put a line in.
The IV is inserted.
She succeeded with that, so now we can start giving medications.
Ow!
Okay. So we can, before we do anything, we'll put some monitors on. So blood pressure and heart rate, blood pressure, or we should do automatic blood pressure really, and then, yeah, that's fine. So his heart rate is 99, So the medication.
The blood pressure is 135 over 90 millimeter mercury.
So we can try giving him some metoprolol. And what we can do, metoprolol will slow down his heart. So what we can try doing is giving him way too much metoprolol. So 7 milligrams is far too much. So we'll give him that. And
7 milligrams
flush the line and see what
of metoprolol has been given. Flushing.
Now, what happens to Mary Murphy if the player in our game does that? And the answer is nothing, because we haven't really coded it in. We would expect this guy's heart rate to drop significantly over the next minute or so. So his heart rate has already started to drop. And we'll see what happens next. So it continues to drop, Have a look at his blood pressure as well. Now 7 milligrams isn't an enormous dose. So what we could do is give him 15 and see if that. No, he's already gone to 81. So he really is. He's getting low to begin with anyway. So let's see how far he goes without necessarily giving him the 15. 77 is still a reasonably normal heart rate, so it's not happening as quickly as I'd like. So we'll just give him the full 15. So he's at 22
milligrams
for now.
Of metoprolol has been given. Flushing.
Really be pretty heavily affected by all this metoprolol. Yeah. Okay. What else could we do for him? That he's certainly not expecting. So we can put a chest tube into him. For somebody who's a collapsed lung, it would be appropriate to put a chest tube in. For somebody who doesn't have a collapsed lung, putting in a chest tube would be not the right thing to do at all. So we'll do that. Insert chest tube. So the expectation with a chest tube is that it would raise your heart rate, because it's very, very painful having a chest tube put in.
The chest tube is functioning normally.
Which is a slightly meaningless piece of information. So the heart rate there is settled at 60 beats per minute. The blood pressure seems to be okay as well. So for some reason he hasn't gone lower than 60 beats per minute. So perhaps another extremely large dose of metoprolol is what he needs. So we'll give that and see what happens next.
15 milligrams of metoprolol has been given.
Okay, it's on the drop again. But just barely so far. It's just sitting around 59, 60. Whereas from my point of view, we've given a near fatal dose of metoprolol. But anyway. So what else could we give him? So some morphine might be appropriate. He's having a bit of pain. So what about if we give him 10 milligrams of morphine and see what that does? Now that should drop his blood pressure, and it should drop his respiratory rate.
10 milligrams of morphine has been given.
Twice.
10 milligrams of morphine has been given.
Flush.
Flushing.
And then we can check his blood pressure again. Let's see what's done. Okay, the heart rate now is 57. Blood pressure you'd expect might drop as well. Okay, it's come down a little bit as well. We'll check it again in a minute or so. So we'll say 1 minute, or just continuous every time. Okay, so we haven't really given anything for his heart attack yet. So, what would be appropriate? I mean, we give him morphine, I suppose, for his pain, so that was something. So we'll give him some saline. We'll give him a bolus. And we'll give him an enormous bolus. So that's 1 liter. We'll just give him 1 liter.
An IV bolus of 1,000 milliliters of saline has been started.
Blood pressure. Now we'll do it again.
An IV bolus of 1,000 milliliters of saline has been started. An IV bolus of 1,000 milliliters of saline has been started.
Fluid. So his veins would be pretty full of fluid right about now. So, okay. What else could we do to this poor man? Put a tube into his nose. See if he likes that. Generally speaking, it's not the most pleasant thing, and if you're conscious, you shouldn't tolerate it. So we'll see if he's conscious.
Hello? Can you hear me?
No, he's not conscious. Are you awake?
Are you awake?
He doesn't seem to be awake. For some reason. I wonder why. Okay. Let's remove the nasal tube. Maybe that's stopping him from breathing. Heart rate is a little bit low, but let's see what it's certainly a survivable heart rate. His oxygen levels are fine. As far as I'm concerned, there's nothing that we've done aside from giving him 20 milligrams of morphine. So that could be a factor. So at this point with Mary Murphy, our expectation would be that the nurse would have refused to give such an enormous dose of metoprolol, and even more so refused to give such an enormous dose of fluids, and then the morphine is pretty unreasonable as well, 20 milligrams. So that would be a protective measure in terms of stopping the player from doing whatever he wanted. So certainly in kind of the early development of the game, the expectation would not be that that we would be able to the player can do whatever he wants. So that the nurse is going to have to police that a little bit. So let's see if we can get him back to reality a little bit. So the dose of naloxone, I think, is 400 milligrams. But if he is not really responding, because of the
What year is it?
I expect his heart rate to have dropped as well. So we'll just check breathing and pulse and make sure that he has a pulse, because his heart rate is 58. What is the respiratory
The
rate?
patient has a pulse and is breathing with some noises coming from the airway.
Okay. And now all of a sudden he's starting to desaturate, I would suspect. So we can put our nasopharyngeal airway back in, which will help with his breathing. And then we'll give him the naloxone, just try and wake him back up a little bit.
0.4 milligram of naloxone has been given. Flushing.
And see how he is now.
Hello, can you hear me?
There. Mr. Grow. No. Okay. Grand. We'll see if he can take any tablets. So, has he had aspirin? I don't know if we've given him any aspirin yet. We'll see. So, aspirin 325. Administer.
325
okay,
milligram of aspirin has been given.
And he's awake. Great. So let's see if he's awake.
Hello, can you hear me?
Yes.
Hear me? Yes.
What's going on?
Good question.
Ouch.
We've woken him up. Ouch. So he's back. Gave him too much morphine. Gave him the naloxone, and now he's back to life. So I suppose a lot of this will be done with math. So depending on a certain number of factors, people will respond differently to different doses of morphine. So every patient will have a variable in terms of how they will react to morphine. I included something about this in the document. If the person is very, very old, very, very small, a mild dose of morphine will affect them an awful lot greater than it would if it was somebody, more robust. So that would be done with kind of math. That would be the expectation that you'd see on the heart rate and the blood pressure, and the conscious level. So he dropped his conscious level because we gave him far too much morphine. We also gave him an enormous dose of fluids, and it really didn't affect his blood pressure too much. Which is probably an oversight on the ACLS. and it just, reality is not necessarily reflected in what the patient responds like with the different interventions, especially the dose of metoprolol that we give. So he's complaining of pain again because we have reversed his opiate with the naloxone. So we would often find that with people addicted to drugs who come into the emergency department having taken an overdose, an accidental overdose, give them naloxone and they feel awful because you've just reversed all of the opiate effect. Anyway, not all that relevant. So, having done nothing for the patient, we gave him some aspirin, I suppose. That was something. We didn't do bloods, didn't do anything. I think we got an ECG, and we figured we should go to PCI. So we'll transfer to PCI and see what happens. Okay, we failed, which was probably a fair assessment of what just went on there. So we got a CT brain, which there was no indication for a CT scan. So that's a feedback that Mary Murphy's treatment would get as well. If they got a CT brain, there was no indication for a CT brain. So if we were to look at it in the ROSC point of view, they would lose reputation with the nursing staff. They would have administered more radiation to the patient than that was needed. Every patient will have a maximum dose of radiation that they could be expected to endure in the emergency department. If you go over that, then you lose points in terms of reputation. The overall, so he's passed. The patient has not done particularly well, especially considering all the terrible things we did to him. So he wouldn't be getting a lot of points for this. Our skills, we succeeded in getting a cannula. But other than that, really, we failed. And then characteristics don't really come into it because there's no personality. There's no capacity to express personality in this ACLS simulator. So important, you gain of history from the patient. Yep. Should have measured the blood pressure. Agreed. Quickly obtain a focus history of the patient. Ask relevant questions. Anyway, we got an ECG, which is correct. Put a line in, and then we checked the OBS. Blood pressure was okay. So then we give metoprolol. The recommended dose is 5 milligrams, so 7 was a little bit much. And then 50 milligram dose of metoprolol was injected. Inject slowly. This dose is dangerous and it may lead to bradycardia. Maximum dosage is 15. Reasonable to give a beta blocker here. So we gave loads there. We gave 30 milligrams of metoprolol, but it hasn't added them up for us. So as far as it's concerned, we've given 15 once, but we've given it twice. And then we placed a chest tube, and there was no need for a chest tube. So that the fact that we placed a chest tube would affect the patient's experience. So if you perform a load of invasive procedures on a patient, so let's say we did the chest tube on Mary Murphy and we did an arterial blood gas, those are two very painful things that will affect the patient's experience. So patients, the expectation is that they will have, some patients won't have anything overly unpleasant happen to them in the emergency department, but then other patients can expect a little bit of misery, whether that be a cannula being put in or a blood gas being done. They will have something of an acceptable level of discomfort as part of their experience. But Mary Murphy and this guy Robert McCrow certainly would not have needed a chest tube. And so that was an experience they didn't need to have. They had a bad experience, which is going to affect the player's overall score. Flushing the cannula. They're mad into me flushing this cannula. And then give morphine. Give slowly. No need to administer more opiates. You might induce respiratory arrest. And then they didn't seem to have a problem with us giving 3,000 milliliters of saline, which could have been fatal. It would have diluted his potassium completely, and could have killed him. We put an NPA, which protected the airway, which was actually needed because of the morphine that we'd given. and then we give naloxone, which is not appropriate because the patient was responsive. They were not responsive. So this is an error of this scenario. So the patient was unresponsive, but they haven't picked up on it. So a lot of this is quite good. A lot of it is so good that it's concerning, because they've managed to achieve quite a bit. But then there are a lot of there are a few holes that you can pick in their capacity for kind of expressing or exhibiting or manifesting what the player has done in the scenario, and that certainly is the case here. So it's not the case here that the player can do whatever they want and they'll be shown what happens. So in this scenario, the player can do whatever they want, but it doesn't. The game will not show you what happens. Now, I did play a scenario earlier on where you can cause the patient to go into cardiac arrest by giving way too much adrenaline, and then the patient just dies, which is it's not a good outcome for the patient. I mean, it's a good outcome for the game, that it will respond to you doing things the wrong way. But what we've shown here is that it won't respond to you doing things the wrong way. In all ways in which you can do the wrong way. I'm rambling somewhat. In Mary Murphy, or in the prototype that we're developing, the nurse will stop the player from doing most of the really bad things that they want to do. And if things start to deteriorate, so their heart rate starts to drop, their blood pressure starts to drop, they start to desat, the player will be moved, or the patient will be moved to resus, and the player, who's a very junior doctor, will not have access to resus at this point, and will lose access to that patient, who will be taken over by a more senior doctor. And at the end of the case, or at the end of the day, or whenever they get their feedback for the case, the player will be told, that patient you saw, Mary Murphy, that we had to bring to resus, she's okay now, but really your management was very, very poor, and this is why. Okay. So we transferred the patient with PCI, which was the appropriate treatment. Okay, that's fine. Grand. Okay, this is similar to our Mary Murphy, and this is FullCode. So we'll see what it looks like when we get into it. So begin. So we can just read through the tutorial, gather the right clinical data, make a differential diagnosis, make the right diagnosis, perform interventions, stabilize the patient, and definitively treat them. After engaging consultants, you will need to disposition the patient to the right level of care. You will be scored on everything you do and don't do. Omitting important actions or performing unnecessary harmful actions will all adversely affect final score. Okay. So this is the tutorial. Reasonably good, I think. Goes through all 8 tabs. Some systems are unnecessary, and your score will be adversely affected. So the idea here is that you're again clicking history taking, but you determine what system. So whether that be the respiratory system or the neurological system, cardiovascular. So if somebody's come in, they've broken their toe, and you're asking about their neurological or cardiovascular system, it's not particularly relevant. So I assume that's what they're going for here, and your score will be adversely affected. So your score is affected in Simmer or in our ED simulator, in that it is you're wasting time rather than your score actually being affected. But there's no clock in FullCode. Patient tab, exam tab. Don't get lost in the weeds. Don't examine everything. Some examinations will be unnecessary. Okay. Stabilize. You can intubate. Choose your drugs. Consider doing this before moving on. Do the ABCs. Okay. Differentials is your diagnosis. All possible diagnoses derived from the ABEM-EM model. So, not sure what that is, but that might be something for me to look up. ABEM-EM. Anyway. You pick your differentials and then you choose your final diagnosis when you're handing over your investigation. So that's, I assume, your blood tests and your x-rays and everything. Okay. What's that last thing there, actually? Results may help, but leave them on your list so you can receive credit for thinking of them at the end of the case. Your differentials. Okay. So they want you to come up with loads of differentials and then rule them out based on your blood tests. Okay, we'll see about that then. The intervene tab, where you really start to finish. Okay, so this is medications and procedures. Many in here are harmful and can lower your final score if not indicated. So it's very much so one case at a time, and there's no real effect. If you make a disaster in this case, there's no kind of follow-on effect. Whereas with, let's say, ED Simulator, you lose reputation, and maybe you'll have a meeting with the consultant if things go really, really bad. Communicate tab, so this is that you can call different specialties. Patients may have friends and family members or co-workers who can provide more context around the case. That's an interesting idea. Time is of the essence. Inadvisable consultations can waste time, which will negatively affect your score. So the idea here, for the first time they've mentioned the word time, but there's no clock. As far as I know, there's no clock. Then handoff tabs, so this is you're referring to the right specialty and you're sending to the right ward. Presented with your score, optional hints for improving your next attempt. Then the scene and nurse. Observe the patient, move around the room with the arrows. Clicking on the nurse, they can give you hints. Okay, and then final advice. Should never be to diagnose and treat the patient. If you have any other questions, feedback. Okay, fine. And then close. Okay, so we'll start with patient. Okay, so we'll have a look at this case properly and see what they've done well and what we can do better, and little flaws that there might be in FullCode, and what's nice about what they do and things like that. So first of all, it looks quite nice. It's a nice setup. Now there isn't full control to move around the room. You can go to the right of the patient, the left of the patient, right up to the kind of the side of the patient, and do that on either side. There are things to click on around the room. So over here we have, I think this is the ventilator, and there are different things you can do in terms of oxygen supply, types of oxygen. This won't necessarily apply to the prototype, because the prototype cases are all taking place outside of resus. So anyone who needs, let's say, intubation or even suction or rapid sequence induction, anything like that, will need to go to resus for that. But I think that's outside of the scope of the prototype. So then other things we can click on, nothing here. It's the same again, and then this is for the monitor and the ECG, so we can attach the monitor. So of note, now this is quite nice. I think this is a good feature to just get all the vital signs up on the screen beside the patient, or their most recent ones maybe. I think it works really well, and these are obviously variables between certain numbers, because the heart rate will kind of dip up and down. The temperature, relatively constant. The oxygen saturations will dip up and down, so that they're variables within a certain number based on other things that you're doing, etc. So then we'll ask for an ECG. I'll just show you this briefly. So the ECG is done. We'll have a look at it. So the rate on the ECG, I can work it out. It's less than 100, so it's around 90. So this is an ECG that's just been done right now, and the heart rate on the monitor is 123. So it's much greater than 100 or 90, which is an ECG. So the ECG monitor is not, or the ECG doesn't reflect the heart rate on the monitor, which I think is a minor flaw, and something that could be improved on. I think it's difficult to always have them matching, but at least the first ECG is likely to be done pretty soon in the case, and why not make it match the heart rate of the monitor. A minor point. We'll see what else we can click on. So this is just IV things. So you can give a bag of fluids, you can put in a line, you can put in an arc line, you can put in a central line. So all these things are easily done and can be done in any order, and it's just a matter of clicking on them. So you can do the arc line if you want, and it just gets put in. There's no failing, there's no learning. The man on his first day in the job can do an arterial line all of a sudden, or the nurse can, and nurses, generally speaking, don't do arc lines and they don't do central lines. So we've put in an arc line and a central line before putting in a cannula, which is it's putting the cart before the horse, it's putting the train before the horse kind of thing. So you've put in an IV there now as well, which is just done. And there's no sign of a central line here, and then on the other side there's no sign of an arterial line having gone in there anywhere. Now they would be in the neck or they would be in the wrist usually, so they're not represented on the patient. So not I mean, it's just I suppose deciding what to do for the patient, rather than doing the little mini games to make it more interesting, that I think that Simmer is aiming to do. We'll have a look at this. So this is probably the ultrasound machine. So the player can do an ultrasound immediately. They don't need, there's no role-playing element where the player is very junior and can't do the thing that they would like to do, which may or may not be the right way to go about it. I like the idea of improving gradually, getting better throughout the game, and actually interpreting the things you do yourself. So for instance, this ultrasound of the aorta, I think it would be nice to learn how to do it, or to at least ask a registrar to come in and help you to do it. Obviously a non-player character registrar comes in, shows you how to do it, and then you review the images yourself. So we'll have some images of what the aorta looks like on ultrasound. Yeah, so anyway, that's how they do it. There's no learning how to do the skill, there's no showing you how to do the skill. It's just, do you want to do the thing? If yes, then you just do it and it's done. Okay. So then up here we have the attending physician. I haven't played too much with this, but there are hints kind of that they give you throughout things. So help me with the diagnosis. It's up to you to figure out the diet, but I've filled in the differential. So review the differential. Okay, so that she's basically just giving me every cause of chest pain. These patients come in with, very obviously they're having a heart attack based on their history, and really we don't need to do any investigation beyond that as far as I'm concerned. You know the diagnosis from the triage note, so there's no ambiguity about it really. It's fairly cut and dried. There are no surprises in this case, as is the case with most full code cases. So what you'll also notice about full code is that there's no timer. So we have been in here, it doesn't tell us how long we've been with the patient. Time is passing, the vitals have stayed the exact same, and everything is as it was when we arrived, whereas we've really been here 7 minutes and we should have done something at this stage. But everything happens immediately. An arc line gets inserted immediately, central line inserted immediately. The patient can go for an MRI of their entire spine, which would probably take an hour, to get them to the MRI machine, to do the MRI, and to get them back, but it happens instantly in this game. So there's no kind of, oh, this patient is too sick to go for MRI, we should probably deal with them here in the cubicle rather than shifting them off to MRI where they could probably die in the machine. Especially a patient like this. So, so then in terms of the patient, we're given the history here. So I quite like that as an idea, that we're given the history. I prefer the simmer thing where you spend a certain amount of time and you get a certain amount of history based on the amount of time that you spend as a currency on the history, and then you're given the past medical history, the medications, their allergies, and then there's kind of an additional history thing. So they've just decided that this is the way to go about it. So to ask about the different systems and then to decide afterwards whether or not it was correct to ask about that system or this system or this system. But there's no real negative outcome. Let's say I want to ask about the endocrine system. And then they just give you a bit of information about the endocrine system. I don't like it. I like that you're given the history. I think this is just this is click fatigue. So there's just so much clicking to be done here, and it's all pointless and not interesting at all. So I don't think it's the best way to go about it. So then we go on to the exam. So we have some general information, which is nice. I like that. And then we can perform, the different types of exams. So a neck exam. So there is a sign of heart failure on the neck exam. I think that by telling the player what is on the exam when it's done correctly, you inform the student what they should be looking for when they do an exam on a real patient. The idea of the student knows that they should do a breathing exam, so they click on breathing exam and then they get some information. It's kind of, I don't think it's that valuable. And this patient's in pulmonary edema as well, so you would expect that their breathing exam would be different. You would imagine there would be some kind of crackles when they breathe in, but maybe that's done in your pulmonary exam. Yeah, so some crackles bilaterally. Okay, fair enough. So like the differentiation between breathing exam and pulmonary exam, I'm not really sure why they feel the need to differentiate there. But fine. Then we can repeat the exam as the case goes on, but it doesn't change. So I think it's a nice idea that you can re-examine as the case goes on, but really it's not particularly relevant. Okay. So then the stabilizing the patient. This patient needs oxygen. So we've been here 10 minutes now and we haven't given them oxygen, even though their oxygen level is low. But there won't be any negative consequences for that. So we put them on some oxygen. And then now they've got an oxygen mask on their face. So some things that you do will affect how the patient looks. So putting in a cannula, putting on an oxygen mask, yes, that will be reflected in the avatar of the patient. But central lines and arc lines are not. Okay. So then we can intubate the patient, which is totally incorrect because they don't need to be intubated. You can start chest compressions, which is also totally incorrect. And then you can shock the patient, which is totally incorrect. So we'll shock the patient. So they get lie down. The nurse has no problems with us shocking the patient. So we shock them and nothing happens. So they still seem to be alive, so that's good. But the nurse didn't object, and it didn't really have any negative outcome on the patient. Now you will get a point at the end to say you shouldn't have shocked the patient. But I think if I do everything right from now on, I'll still get a pretty good score. So let's see if that's the case. So we'll forget about the exam. We'll do our differential. So we'll say this is an MI. We can remove all the rest of them. That was a nice little differential. There. Okay. So then investigations, we should do some bloods. So we'll do we've done an ECG. We've done an ultrasound of the aorta. Should do a heart ultrasound as well. And then lab work. We can do the basic chemistry, and we can do an FBC, D-dimer, lactate, and pro-BMP, and a troponin. So all that is correct. And then the other labs. So you can actually do a lumbar puncture, which is a spinal tap of the patient, and the nurse never objects, the patient never objects. You just do one, and you're told at the end that it was unnecessary, but it wasn't harmful. But in a similar scenario, you will be told that you made the patient uncomfortable unnecessarily. So if you do loads of unnecessary investigations and loads of painful things to the patient that they don't need, you'll lose points, and you'll end up with less points for the case, and you'll lose reputation and all that other kind of stuff. But here you can just do a spinal tap, which is a very painful, unpleasant procedure, and a chest x-ray. So we'll do all those and we'll perform them, and I think you just get the result back immediately. So there you go. So there's no waiting for the bloods to come back. It's just all back all of a sudden immediately. So the troponin is a little bit high, and there's pulmonary edema on the chest x-ray, which is actually reported for you. So there's an interpretation of the chest x-ray down here. So the student or the player doesn't even need to investigate or to interpret the ECG themselves. So then that's all fine. So we're correct in thinking that this is a myocardial infarction, and we should give some medications for it. So they're in cardiogenic shock. So what are we going to give? So we should give some aspirin. We should give nitroglycerin. We might hold off on just because the blood pressure is already low. It would not be unreasonable to give this patient some epinephrine, which would be under vasoactive agents. So we'll put them on an epinephrine drip. And can I undo that? So let's say I clicked on that by accident. Yeah, I can undo that. So that's good. Okay, we're given aspirin, we're given that, and we can see what the cardiologist says after we've done these different things. So we're on the epinephrine drip. Okay, blood pressure's come up, heart rate has also come up. We could give a little bit of fluid maybe. How much though? A normal saline infusion. Okay, so give that, and then we'll communicate with the cardiologist, who will say, concerned about these, you can't take so recommends pharmacologic options if there are no contraindications. So that's fair enough. So we have the diagnosis, and we're going to admit to ICU. We've given aspirin, we haven't given any pain relief, but that's reasonably okay. We've given the thrombolysis, and we've given some epinephrine because of the cardiogenic shock. So we'll admit to ICU with an MI diagnosis. Okay, so finish and see what happens. So we still got a pretty good score. We attempted to kill the patient quite significantly throughout that, but still got a reasonably good score. So we can use an unlock credit. Now I've actually paid for the pro version of this, but there's a problem with how it's loading up on a laptop compared to on a different laptop, which is a problem with FullCode, obviously. But anyway, so we get 72.9, which is pretty good, or it looks pretty good anyway. We'll unlock the credit and see what happens. Okay, so we got the diagnosis right and we got the disposition right. We didn't do any review of systems, so we didn't add any other history other than what we were given. And then in terms of physical exam, we only did a little bit of it. So stabilization, we got 100% investigations, 100% interventions. We lost 80% because we shocked them. So that's actually reasonable enough that they told us that we shouldn't have defibrillated, and we were told that it was harmful. And we were harmful to give an epinephrine drip as well. So we can click. Can we click on the different things? No. Fluozolone will not correct this patient's hypertension, which is why I gave the epinephrine drip. Anyway, so we did the CVC. We did an art line, which is neutral. We were told the central line was unnecessary, which is fair enough. And then we defibrillated, which was harmful. We gave aspirin, which was a good thing to do. We gave epinephrine. We gave fluids. Okay, so right at the end, then we were told we did 2 harmful things, 1 unnecessary thing. Only 1 out of 4 of the critical things, and none out of 0 to 0 of the recommended things. Anyway, fine. We have no unlocked credits left, so we may as well make the best of this. So, ST elevation, so need emergent stabilization with cardiogenic shock and thrombolysis. So we gave aspirin. What else did we do? We didn't give heparinization. We gave thrombolytics instead. Anyway, and we started vasopressors. Okay, a small IV bolus of fluid. And then the bed, echo, and then norepinephrine, yeah. Bolus and infusion, normal saline. Okay. Okay, I feel like we did give a good deal of this, but the game doesn't seem to have picked it up. Cardiology can't take the patient, emergent thrombolysis, and we gave the tenecteplase. So it seems like we gave quite a few of the things that we should have given, but we haven't been given credit for it. And then we sent them to ICU. So that's surprising. Okay, fine. So giving thrombolysis isn't going to be something that's done in the cubicle. That's something they're going to go to resus for. Mary Murphy in the similar scenario is going to have reasonably good access to go to the cath lab for her angiogram and her stenting, so we're not going to need to thrombolyze them. So that's not going to be an issue in terms of doing things in the right order. Maybe that was the problem. I'm not sure. Anyway, we didn't get credit for the things that we did. So we can click on the different things. So we didn't do a cardiovascular exam, or cardiovascular history, and we didn't do a respiratory history, even though we were told in the history that we were given that all about the chest pain, and we were told that they have shortness of breath in the little bit of history. So this is not helpful. We didn't really do a gastro history. Anyway, and then ask for leg swelling concerning for heart failure or DVT. So that's kind of the thing. So musculoskeletal history to involve leg swelling. It's not like leg swelling isn't because of the muscles or the skeleton. So it's just an odd way of phrasing it, and I don't think it works. And then we did an endocrine history, which is neutral, because it was irrelevant. Okay, then physical exam. So they wanted us to do 4 types of physical exam. Not particularly relevant, really, or helpful or valuable to a student to click breathing exam, circulation exam, cardiovascular exam, pulmonary exam. It's not that helpful. I think there's a better way of doing an exam, and I think the way that it exists in the similar scenario is better. Okay, then stabilization. So we gave an IV and we put in a monitor. We gave some fluids. But we didn't give them in the stabilize tab. We gave them over in the intervene tab, which is what they had problems with. And then we intubated. No, do we intubate? Pre-oxygenate for intubation. No, we didn't intubate. Again, quite confusing. Investigations. So we did almost all of the. We should have done blood type apparently. Never once done that for a patient with chest pain, but whatever. Okay. I wouldn't have taken any points off me for not doing it, and they didn't either, so that's good. We did the 2 critical ones, which was get an ECG and get a chest X-ray, and then we also got a troponin, which is reasonably correct. And then the interventions we saw already, and the communications, talked cardiology, and that was it. So I mean, it's not. FullCode is described as serious learning, serious fun, which I think is not describing it particularly accurately. It's not fun. There was nothing really fun about that. Nothing interesting happened. A lot of it was confusing. A lot of it was messy. Now I've played through a few of these, or I've even played through this case a few times, and I'm still kind of finding my way around it. In terms of having a look at the attending physician and getting hints, it's not that, and it's not a very interesting way of doing it. And then the nurse just doing whatever you say without questioning anything. I mean, it's almost an insult to nurses, really, that they're just there to do whatever the doctor says, because in my experience they are not. So I've run through a few other versions of this. I've done loads of things wrong with the patient. It's very hard to make them go into cardiac arrest. I've gotten the patient's blood pressure down to 30/18, which is it's incompatible with life. It's so low that the blood pressure cuff wouldn't even pick it up. And the nurse kept giving the medications that were going to drop the blood pressure even more. So there's nothing really to prevent the person from just trying to kill the patient, and there probably should be, and there will be in the simmer scenario. So I think that's a reasonably good overview of what FullCode looks like. This is a fairly straightforward case of chest pain, and it's not seriously fun. We'll see what else the attending physician can do. Advice in investigating the patient. Did you look at the ECG? So the moving around the room is nice, but it's more resus. I think this is more appropriate for resus. I think for the patient in the simmer scenario, actually being a person, role-playing a character, role-playing the doctor, is a much more interesting or appealing way of doing it. I think we have a lot of things that are better potentially than FullCode. I think FullCode is great, but there are certainly some flaws, minor flaws, and then things that are missing that would make it more engaging, more immersive, and more fun.